Hello students, myself Dr. Thangabalu, Assistant Professor from Department of Orthodontics, Vinayaga Mission Sankaracharya Dental College, Salem. So today we are going to see topic on deep bite. So in deep bite we are going to see a contents about various definitions of deep bite and what is normal bite and classifications of deep bite, diagnosis and various treatment modalities and conclusion. So on introduction, basically in orthodontics, we can generally broadly classify the malocclusion into the three dimensions. For example, in sagittal dimension, that is anteroposterior, we can classify into class 1 malocclusion, class 2 and class 3 malocclusion. Similarly, in transverse dimension, we can say about the cross bites, scissor bite and telescopic and various bites in transverse dimension. In third dimension, we will look in the vertical dimension, that is either open bite or deep bite. So in vertical dimension, first we are going to see about the deep bite. So generally, deep bite is one of the frequently seen malocclusion that occur along with the other associated malocclusion, but severity is mostly associated with the skeletal hypodivergent cases, typically in class 2 division 2 cases. It is said to be one of the most perpetuating and damaging malocclusion as it may jeopardize the periodontal support and occlusion itself or TMJ. It will damage the periodontal integrity of the periodontium. It's due to it will encroach that basically deep bite will encroach the, for example, skeletal deep bite will encroach the freeway space. So there will be a limited freeway space that will lead to jeopardize the TMJ and also integrity of the periodontal ligament. So excessive overbite is a complex orthodontical problem that may involve a group of teeth or whole dentition, alveolar bone, of maxillary and mandibular basal bone and or the soft tissue of the space. Deep bite involves the malocclusion. It also affects the maxilla, mandible or soft tissue. Basically it's classified into two types, either skeletal or dentoalveolar. So the various definition given by the authors, these are the various definitions. First one is given by T.M. Graeber, that is a condition of excessive overbite where the vertical measurement between the maxillary and mandibular incisor margin is excessive when the mandible is brought into the habitual or centrical occlusion. So that is very important. When the patient bring the mandible into habitual or centrical occlusion, the incisal overlap should be more beyond the normal overbite. And second definition was given by the Profit. The deep overbite or deep bite can be defined by excess amount or percentage of overlap of the lower incisor by the upper incisor. So first we look about what is normal bite. So in this diagram we can you can see that there are various zones. That yellow zone, this is a normal overbite, that is 5 to coverage of lower incisor is 5 to 25% by the upper incisor. So this yellow zone is the normal overbite. When it beyonds yellow zone, it is considered as the increased overbite or excessive deep bite. There's a three classification. When it covers a 5 to 25%, it's a normal, or it goes beyond 25% to 40%. That is we can say very next to that. That is orange zone. That is called as a overbite, increased overbite. And final one is a deep bite, that is beyond the orange zone. We can see that the red zone. When it goes beyond 40%, it is called as a deep bite. So first we will look about the classifications. Classification majorly divided into developmental and acquired and functional and according to the dentition. So first one, developmental, either it may be a skeletal deep bite or dentoalveolar deep bite. Skeletal deep bite is mostly occurred with the horizontal growth pattern patients and anterior excess, vertical anterior excess. And second one is a dentoalveolar, that is due to the either maybe a two abilities, that's a supra eruption of the incisors and infra eruption of the molars. And what is acquired? Acquired is due to lateral tongue thrust, any habits of lateral tongue thrust and early loss of a deciduous teeth that leads to the lateral spread of the tongue that will prevent the eruption of the molars. And third one is the wearing of occlusal surface. So what is functional? Functional is either true deep bite or pseudo deep bite. True deep bite is mostly associated with the skeletal deep bite, and pseudo will be supra eruption of the incisors. It's mostly associated with the dentoalveolar. And final one is according to dentition, it's a primary dentition deep bite and mixed dentition and permanent dentition deep bite. So how will you diagnose this? For a diagnostic, what are the ornamentariums we need? basically we can diagnose with the study models. Study model is the essential diagnostic aid. So that's a very helpful in diagnosing a deep bite, and we can easily measure how much the amount of or severity of deep bite. And second is the cephalograms. Cephalograms will help us to determine the growth patterns, and we can see the planes, various planes of the skull that can be face, various planes of the face that can be easily identified using the various analysis mostly. And finally photographs and by the clinical examination also. So first we will start with the clinical examination. First one is the extraoral examination. Extraorally patient will have a short square face. So you can look at the diagram. The patient will have a normal upper and lower middle third of the face. This is the upper and middle third of the face, that is normal. But if you look at the lower third of the face, that will be very small. And also patient will have a broad alar base. So most commonly you can see is in frontal photograph, that is a small lower face, lower third of the face. And in lateral view we can see that patient will have a retrognathic mandible. So mostly patient in deep bite cases they will have a retrognathic mandible. And also look at the gonial angle, that's small gonial angle, and also the mentolabial sulcus will be more. And if you see patient will also have a lower third of the small lower third of the face. So intraorally you can see most of the cases is a dentoalveolar. If it is a dentoalveolar, there will be a the classical example is a class 2 DVT case. So patient will have a retroclined incisors that will lead to the supraeruption of upper incisor that will cause a deep bite. So it's mostly in dentoalveolar cases. Maybe combination of a dentoalveolar and a skeletal deep bite will be also present both. But in purely, if it is a dentoalveolar, there will be two possibilities: maybe supraeruption of the maxillary incisors and infraeruption of the either maxillary and mandibular posteriors. So study models. These are study models. You can easily we can look at the patient as a class 2 DV2 case. Look at the retroclined incisors. So it's almost cover the lower incisor. We can call it as also closed or cover bite. Look at the lower incisors, so how much it's a supraerupted, and the posterior. If you look at the occlusal plane, the curve P will be very deep. So next one is a cephalometrics. Cephalometrics, as I told earlier, if it is a skeletal deep bite, all the planes like ascent plane, Frankfurt plane, palatal plane, occlusal plane, and mandibular plane, all the planes will be, look at the planes, almost it's parallel. But so this is a pure skeletal deep bite case, and this is a dentoalveolar. If you look at the planes, that's are not almost parallel to it, it's diverging each other. So this is not a skeletal case. We can easily differentiate by using these cephalometric methods. We can call it as that's analysis used as a Sassoni analysis that will be helpful in differentiating the deep skeletal or dentoalveolar deep bite. And this one is a combination, will be mixed both. So as of now we have able to identify the what is a skeletal or a dentoalveolar deep bite. Now we'll move on to various treatment modalities. So factors should be what are the factors should be concerned while treating the deep bite cases. If it is a skeletal deep bite, first we have to identify where to diagnose the case, whether the patient is in a growing or non-growing patients. Whether it is a growing, the treatment modalities will be different. Non-growing patients, treatment modality will be different. So first we'll come with the dentoalveolar deep bite. First thing, for the factors first we have to look on is upper incisor display. See, if we look at the upper incisor display at the wrist, it should be up to 3 mm it's acceptable. 2 to 3 mm it is acceptable. If it is more than 2 to 3 mm, for example, if you look at this picture, we can see there is a visible of gums, gingiva. So usually we will call it as a gummy smell. So in these cases we have two options. The deep bite corrections can be done by the either two options. First one is a intrusion of incisors and extrusion of posteriors. So these are the factors. First factor is upper incisor display. If there is a excessive visibility of a gum, in that cases we have to intrude the upper incisors instead of extruding the posteriors. Second factor is smile line. Ideally, for male patients, while smiling, 75% of the upper incisor should be visible, and for female, 1 to 2 mm of the gingiva can be visible. That is a acceptable one according to Profit. And if you look at this first picture, the patient have a very good smile and has a smile arc. The smile arc is nothing but the lower lip should follow the incisal edges of the upper incisor. So the first picture is a perfect one. The patient have a good smile arc and perfect smile line. And second patients have a average lip line. So it's also acceptable. And third one is patient have a low lip line and her smile is not good. So what are the factors while I have to consider when the patient have a different lip lines? So for example, in the first case, the patient is a perfect one. So just leave it. And the patient in the third picture, if you look at this third picture, if the patient have a deep bite, in these cases, we should not intrude the incisors because already the patient have a low lip line. If you intrude the incisors, the low while smiling, the upper incisor will not be visible, so that will not be aesthetic. So in these cases, we have to extrude the posteriors. So what are the methods? First, we will look at the removable appliances. So anterior bite plate, sweat type bite plate, and tongue crib appliance and S6 intrusion appliance. These are the 4 appliances. These are removable appliances useful to correction of a deep bite. So first one is the anterior bite plate. It was given by Miller. The mechanism behind the anterior bite plate will be, it will open the bite posteriorly 1 to 2 mm. This is the anterior bite plate given. It will the lower incisor will hit the anterior, the bite plate present in the anterior, so that will open the posteriors by 1 to 2 mm. So that will happen. What will happen in these cases? The extrusion of posteriors will occur. We should not open beyond 1 to 2 mm because if we open more than 1 to 2 mm, lateral spread of the tongue will occur. So that will impede the eruptions of the posteriors. So that should be very careful while giving an anterior bite plate. 1 to 2 mm should be opened posteriorly. And similarly, sweat bite plane, this is a modification of anterior bite plane that only anterior capping will the incisal capping will be present, that will prevent the proclinations of the upper incisor. This is a modification. And posterior tongue grip, in the patient has the lateral tongue thrusting habit, so in that cases that lateral spread of tongue will prevent the eruption of the molars. So in that cases we have to give a posterior tongue grip. Look at the tongue grip. And A6 intrusion appliance. So this will this is a A6 intrusion appliance. See, so this will resolve the excessive tooth eruption. The fixed appliances can be frustrating because the coincidence extrusion of adjacent teeth will usually more evident than the intrusion of over erupted teeth. This appliance does not any clasp. It's easily constructed and can be thermoformed from a single 1 mm sheet of A6 plate. Like nowadays we are saying the clear aligners. Similarly, the A6 appliance will be there. With myofunctional appliance during a growth stages, if whatever the debate, if we correct during the growth stage, if the patient is in a growing stage, if we correct the debate, that will be more stable. And the reason is, during growth stages there will be a vertical development of the bone, alveolar bone. So that will help the most stability, stability of the correction of debate when we do in a patient in a growing stage. So various myofunctional appliances are there. Most commonly you can see the activator and bionator. For example, in activator, we should give in debate cases, we should intrude the incisors that can be achieved by loading incisal edges of the teeth. See, look at the acrylic plate. That will cause the intrusion of the both upper and lower incisors. And similarly, for eruption of posteriors, we have to remove this acrylic plate covering the molars. Similarly, functional regulator and using tin block appliances. This is very important because most commonly used appliance. Tin block appliances, look at this is the trimming area. We should not trim this. This is the inclined plane, so we should not trim this, and this inclined plane should be trimmed 1 to 2 mm. This also we should not trim more than 2 mm. This is because of the lateral spread of the tongue will prevent the eruption of the molars. So next is bonded bite plates or removable bite plates. See, these are the removable bite plates. So if you look at the first picture, there is a clear deep bite case, and this is deep bite is corrected using this bite plate. And third one is we can use also bonded bite turbos. See, look at that's directly given bonded in the upper incisor, that will cause the intrusion of the lower incisors. as well as upper incisors also. But in these cases, there will be possibilities of a proclination of upper incisors because there is no control. So correction of up to this we have seen about the removable appliances, the correction of debite by using the removable appliances like para-tube bite plates and biofunctional appliance, these things. Now we will come with the fixed appliances. So this is very deep. I am not going in detail. So just have a look, and these are the various intrusion arches given by the various authors. So first one is a 3-piece intrusion arch. This arch will be in a 3-piece, and Ricketts utility arch and Mulligan's intrusion arch by opening and space closing wire, and KSR appliances, Connecticut, that is a CNA, Connecticut intrusion arch and intrusion with the mini implants. So this everything is go on a intrusion, only intrusion. Basically the removable appliance will be a combinations of intrusion of incisor and extrusion of posteriors. But in these fixed appliances, these intrusion arches, utility arches are mostly concerned with the only intrusion of the incisors. And first one is intrusion. Similarly, there is a extrusive mechanics. That's a tip back mechanism, base arch mechanism, and 1/6-inch distal extension, parallel eruption of buccal segment, debite correction with the magnets. So these are very deep. I'm just giving the names. Just take out the names. So first we look at the basic intrusive arch mechanism. There will be 3 units. Posterior anchorage unit will be there. This is a posterior anchorage unit, and this is anterior segment, and this is anterior segment and intrusive spring. So basically any intrusive arch will be contain these 3 segments: posterior anchorage unit and anterior segment and intrusive spring. So first we will look about the various things given for us. First one is an anchorage bend. This is nothing but this is a lower and for intrusion of lower anteriors. So this is an anchorage bend is given. Usually the wire will be straight. So in this, the anchorage bend anterior to the molar, we will bend like this. We give a bend, cable bend, that we can call it as a cable bend or anchor bend. So this is in passive. The wire, this is the wire when it is in passive. So when we engage the more anteriors, what will happen? This intrusive force will occur due to the anchor bend. And similarly, when there will be always a opposite reaction will be there. When there is an intrusion of incisors, mild extrusion of posteriors will be there. So Newton's third law, every action has a opposite reaction. So second one is a arch wire, is a reverse Kawaspi. Reverse Kawaspi, nothing but the arch wire will be like this, straight. This is straight arch wire. So reverse Kawaspi will be like this. We have to bend like this. So this will cause the extrusion of the posteriors as well as the intrusion of the anteriors. And third one is a intrusion arch, as I told earlier. So this is a posterior segment, an intrusive spring, and this is a anterior segment. So this is a cable bend, 30 to 40 degree. The cable bend should be given. So when we engage this segment, this is inactive. So this is passive. When we tie to this anterior segment, that will become active. That will cause the intrusion of the incisors, like this. So similarly, the utility arch for intrusion of anteriors and V bend, there will be a lot of modifications. So basically intrusion arch is just a cable bend given anterior to the molar, that will cause the intrusion of anteriors. So these are all the conventional techniques what I have seen. Now this is the use of skeletal anchorage system. Skeletal anchorage system, the first reported by Creekmore and Eckland. So this will help, like we have to place the implants here in between the incisors, or to the single implants that can be used, or to implants that's lateral to the lateral incisor. We can place that, and we can apply a force from here to the anterior segment, that will cause an intrusion of the incisors, anterior segment. So why we are using skeletal anchorages? As I told earlier, there is always a adverse effect will be there. While intruding the incisors, there will be a mild extrusion of the posteriors. In that case, we can avoid that by using a skeletal anchorage system like temporary anchorage devices or mini implants. So up to this, we have seen about the intrusion of the incisors. So again, one is a extrusion mechanics, extrusion of the posteriors, how we are going to see. So what is the benefit of extruding the molars? Every 1 mm of extruding the molar will correct the debite by 1.5 to 2.5 mm according to the Gaffari. So extrusion of posteriors by 1 mm will open the bite by nearly 1:2 ratio. So First technique is leveling the cover P. Look at this upper arch, the cover P is going like this, and so in these cases we have to put the cover P in upper arch and reverse cover P in lower arch. So it will extrude the posteriors by around 2 to 3 mm. That will help in correcting the debate, and include the posteriors as second molars. So second molars, the fulcrum is present in very posterior segment, so that will help in relieving a deep bite when compared to the first molar. So whenever the deep bite cases come, try to include the second molars from the beginning. That will help to relieve the deep bite and increase the step bends. We can see that step bends in the anterior segment in upper. This will cause the intrusion of upper anteriors, and counter moment will be there. There will be extrusion of posteriors also. And you can use a class 2 elastics also. The class 2 elastics will help in, there will be a two vector of forces, that is, one is horizontal and vertical, and combinations of both. So this horizontal vector force will help in anteroposterior correction like class 2 correction, and this vector of force will cause the eruption of posteriors. That will help in correcting the deep bite and eruption, and this will this class 2 elastics will also cause the supra eruption of upper incisors. To counteract that, we have to give a counter moment like cover P in the upper arch. That will help in prevent the eruption of the upper incisors and extrusion of the posteriors. So that will help in correcting the deep bite. So up to this we have seen about the various treatment modalities. But first we have seen about the removable appliances and myofunctional appliances in growing patients, and next one is a fixed appliances. In fixed appliances, various intrusion arches we have seen, and extrusive mechanics also we have seen. So now we have completed the treatment part. These are mostly for growing patients, and it's a dentoalveolar or skeletal debate. When a non-growing patient with this severe skeletal debate is present, the only option is we have to go for a orthodontic surgery. So in if you look at the stability of debate correction in severe skeletal debate correction cases in non-growing patients, that's if you correct the dentoalveolar, there will be a maximum chances of relapse. So better we have go for a orthodontic surgery. See, if you look at the stability, study by Burzin and Nanda, study the stability of debate correction by incisor intrusion in 26 patients treated for 2.3 years in the post-treatment observation of 2 years. So in that study, there is a debate reduction by 3.5 mm and post-treatment relapse of 0.8 mm. So net rate of 3 mm is a debate correction is stable over a period of 2 years. And maxillary incisors include an average of 2.3 mm and insignificant relapse of just 0.1 mm is relapse. So there is a maxillary incisor more stable. So they concluded that overbite correction by maxillary incisor intrusion was a stable procedure. So once we correct the deep bite cases, the retention protocol we have to modify is we have to give a modify Beck's retainer with the anterior bite plate. So that will prevent the supra eruption of the lower incisors. So that's a very important. The retention up to what retention should be maintained until active growth has ceased. Sometimes until 21 to 22 years we have to give. So according to Profit, the retention should be needed for several years after treatment as vertical growth continues into the late teens, and bite depth can be maintained by wearing a retainer only at night after stability in other regards has been achieved. So what are the factors should be considered during the retention is, first one is age. As I told earlier, the debate correction should be done during a growing patient. The growing patients benefit the most with this approach because the active vertical growth during debate correction ensures the greatest stability. So for the patient in a growing stage, the retention will be very good. So up to 20-21 years we have to give a retention appliances. After that, the stability will be good. And second one is a facial type. In facial type, hyperdivergent, we know that vertical grower and horizontal grower. In vertical grower patient, the stability will be good because there will be a vertical growth of the alveolar bone. So look at the hyperdivergent facial type. So that's a vertical growing facial type. Usually exhibit a more favorable reaction to the overbite correction and compared to the hypodivergent, because due to the growth rate in the vertical direction. So there is will be increase in growth in vertical direction, that will help in the growth of the alveolar bone. So that will be helpful in a vertical grower patients. But in hypodivergent cases, there will be growth in a horizontal direction. So that will be always a problem and very difficult in correcting the teeth bite. And stability is also questionable, because in hypodivergent cases there will be a high masticatory force will be there. So that will lead to the more chances of the relapse. So that should be concerned. And molar extrusion or incisor intrusion. So the stability of molar extrusion in growing patient is fairly stable procedure if the interocclusal space is not violated. The normal 2 mm of freeway space should be there. We should not encroach that. So any eruptive movement beyond the interocclusal space might not be stable due to stronger posterior occlusion or muscle stretching, especially in a low angle individuals. As I told earlier, in low angle patients, we should not encroach the freeway space. That will lead to high masticatory force, and that will cause the relapse of the debate correction. So we are concluding this topic. So debate is a common form of the malocclusion that may be addressed in many ways, and each specific approach should be based on each patient's need to deliver a goal-oriented treatment. Understanding the biomechanics of the applied institution improves the clinician ability to achieve the desired results. Non-surgical correction of debate includes the molar intrusion, and incisor intrusion, and combination of both. Only 2 options will be there. And 3 main orthodontic mechanics constitute the basis to correct the debate is intrusion of incisor, extrusion of posteriors, and proclination of incisors. These 3 things is the most common while using the either fixed or removable appliances. These modalities are indicated separately or in combination depending on the diagnostic component analysis. So these things, extrusion or intrusion of anteriors or proclination of incisor, these 3 things can be combined or individually given to the patients depending upon the diagnosis, what all the diagnosis we have done and need of the patient. So successful treatment of debate correction depends upon elaborate clinical examination. We have to clinically examine the patient thoroughly, thorough cephalometric analysis, and good treatment planning and proper retention protocol. So stability of debate corrections may be depend on the specific nature of its correction, either intrusion, extrusion, or flaring. That's a proclination of incisors. Additionally, various factors such as growth and neuromuscular adaptation may play a specific role in relapse. Thank you. Thank you for watching my class.